Hey, good afternoon, everybody. Thank you so much for joining us for today's MADC speaker series. My name is Stephanie, and I will be monitoring things here on the back end. Because we are expecting a pretty large crowd today, I'm going to request that we keep questions towards the end. So we'll leave a whole chunk of time for questions at the end. And feel free to put them in the Q&A or the chat, and I will be going through them and hopefully get to as many as possible. Also, keep your eye on your email. Tomorrow, I'll be sending out an evaluation. So please fill out the evaluation. We really value your opinions on how things go. And I'd like to hear about other topics you might want to hear about in the future. That being said, our next speaker series will be March 20th, a month from today. From 12 to 1, Dr. Shreya Robinson Lane will be presenting It's a Family Affair, Culturally Responsive Dementia Care for Equitable Health Outcomes. And with that, I'd like to turn things over to Dr. Scott Roberts. Dr. Roberts is a professor in the School of Public Health. His research addresses ethical and psychosocial issues involved in diagnostic genetic test information in areas including Alzheimer's disease, hereditary cancer syndromes, direct-to-consumer genetic testing, and workplace wellness programs. With that, you can take things over, Dr. Roberts.
Yeah, thanks, Stephanie. I appreciate the introduction, and it's great to have folks joining in today. Yeah, as you can see from my title slide here, I'm going to be talking about genetic testing for Alzheimer's disease, and it's a topic I've been interested in for many years now. But we're actually in this new era of Alzheimer's treatments with some of the recently FDA-approved therapies that has genetic testing having new implications just in the past couple of years. So I'll be talking about some longstanding issues in the field as well as some new developments. So look forward to sharing this with you. But before I get into genetics, I wanted to remind us all that Alzheimer's is a multifactorial condition. That is, there are many risk and protective factors that we know about. So it's not just genetics that are important to think about here. And of course, you probably know that age is the most prominent risk factor for the disease. And you can see some of these other well-established risk factors on the left here. Family history is important. Women are actually at elevated risk of Alzheimer's disease. Fortunately, there are some protective factors as well, and you can see these listed on the right. So there are things one can do to reduce one's risk of disease. A lot of these are healthy behaviors that we recommend for other common conditions like heart disease or diabetes, so healthy lifestyle. And some might be particular to cognitive health, like staying mentally active. So none of these are absolute magic bullets for making sure you don't develop Alzheimer's, but there are some things one can do to lower one's risk. So I did want to kind of make that clear up front, because when we talk about genetics, sometimes people think of it as destiny, that if you have a genetic risk for a condition, it's inevitable, and that's certainly not the case. But when I talk about genetic testing today, it's a many splendored thing. So I'll be talking about different types and purposes of genetic testing. So you can see the ones in bold here are the ones I'll focus on as most relevant to Alzheimer's, but you may have heard about other types of genetic testing in other areas of medicine and public health. So given we're learning all the time about the genetic roots of many different conditions, it's certainly become a hot topic throughout medicine. And so Alzheimer's is no exception. So this table here shows that when we talk about genetic testing for Alzheimer's disease, it can be used, for different purposes with different target populations. We can focus on different genes that we test for, and it's done in different contexts. So I think we often think of clinical practice, but it's done routinely in research. And I'll talk some about, there's even direct-to-consumer genetic testing options now. So I'll get into these different purposes and populations and genes, but just wanted to kind of mention that at the outset, that it's really not just one kind or one gene that we're talking about, or even one testing context. And when we think about the different genes we might test for, I think they do vary. Some of these are very rare, but have very big effects on risk of Alzheimer's. Some of them are more commonplace in the general population and might have moderate size effects on disease risk. And a lot are relatively common, but have kind of minimal effect. And so it can be pretty complex to think through all these different genes and the different kinds of effects that they might have on risk of Alzheimer's disease. So let's talk about first those rare mutations that do have a major effect on Alzheimer's risk. And so we've known about these genetic mutations for decades now. So there are rare mutations located on chromosomes 1, 14, and 21, where if they are present, the carrier will almost inevitably develop the disease. So some of you may have heard of these genes, the amyloid precursor protein or presenilin genes. And so they're very important to think about. However, they are very rare, so they account for a small minority of Alzheimer's cases. But when they are present, they can cause disease, sometimes even in one's 30s or 40s. And when the disease is present with these mutations, the course of symptoms is often more rapid than we see in later onset Alzheimer's disease. Some of you may have seen the Oscar-winning film Still Alice that depicts Julianne Moore plays a college professor who has one of these rare genetic forms of the disease, and you see how the drama unfolds in her family. And like, for example, should her adult children be tested? So the dilemma often in these cases is should the adult children learn their risk as well, because they have a 50-50 chance of inheriting the mutation from an affected parent. So for these kinds of situations, we do have genetic testing and counseling available at specialty clinics. U of M is an example. And usually in this kind of situation, we have genetic counselors as the professionals who deliver the information. So I thought I'd say a little bit about the field of genetic counseling. So these are master's level clinicians who have training both in medical genetics and also in patient education and support. And so in familial Alzheimer's, they usually have kind of a pre-test session to go over what the test will divulge and the implications it would have, and help people think through, do they really want to pursue this kind of testing? Because it doesn't always inform medical care. You may have heard of Huntington's disease as kind of a similar situation where profound results, but does not necessarily lead to, oh, here's this proven prevention that we can offer you. So genetic counselors help patients and families think through the implications. They often handle the post-test disclosure as well and provide recommendations. So genetic counselors are fantastic resources in this realm, but they are relatively few in number. So I think one challenge for the field that I'll be talking about is, as we think about genetic tested being expanded, one question is, how do we think about other providers who maybe have less genetics expertise also handling this information, whether it's primary care docs, geriatricians, neurologists, et cetera. So that's a little bit on those kind of rare high penetrance mutations that we call them, that almost inevitably cause Alzheimer's. But I think for most people, perhaps the more relevant gene to think about is the ApoE gene that some of you may have heard about. So this is a plasma protein on chromosome 19. We all have an ApoE genotype, and we all inherit one allele from each parent. And the three common ApoE alleles that are out there are E2, E3, and E4. And it's the E4 allele that's the well-established risk factor for Alzheimer's. So having an E4 allele elevates risk of the disease. But it's important to know that unlike those rare mutations I was just talking about, having an E4 allele is neither necessary nor sufficient to cause Alzheimer's disease. So you could have an E4 allele and never get the disease. You could have the disease but not be an E4 carrier. And having two copies elevates risk higher than just one. Interestingly, ApoE-related risk does differ by sex and ancestry. So the effect of the E4 allele seems to be more pronounced in women. And interestingly, people of Japanese descent, although people of Japanese descent are just less likely overall to be E4 carriers. And some more recent research out of Stanford University suggested an interesting interaction between the E4 allele with a certain rare variant of the E3 type. So people with this combination, one E3 that has a particular variant and one E4, in people of African descent are at elevated risk for the disease. So people with that particular subtype have about the same risk as E4 homozygotes, which was interesting. So that research was just published a couple of years ago. So as you can kind of see, it's pretty complicated stuff to think about here because we're talking about different genotypes, we're talking about different populations. And to make matters even more complicated, ApoE is also relevant to other conditions besides Alzheimer's. So E4 is a modest risk factor for heart disease. And interestingly, the E2 allele is seen as protective against Alzheimer's, lowering risk of Alzheimer's, but then elevates risk of a certain type of hyperlipidemia. So it's no wonder, given all this complexity, that we often, in an ideal situation, would have genetic counselors being the ones to help explain this to folks. So just to give you a sense of ApoE genotypes in the general population, so these are the different combinations one can have. And remember that people who have an E4 in their genotype, remember I said we're at higher risk. And you can see E4 carriers are relatively common in the general population overall. So about 1 in 4 folks in the general population have at least one E4 allele. And you can see about 2% of the general population have two copies. So that E4 is the highest risk genotype. So I think that's important to keep in mind. And what does it mean in terms of Alzheimer's risk? Well, you can see the general population lifetime risk of Alzheimer's is about 10 to 15% chance. And you can see having one copy of E4 about doubles that risk. And then having two copies of E4 makes one multiple times higher chance of getting Alzheimer's. So about a 45 to 60% lifetime risk of disease. So certainly high risk if you're E4, but compared to those rare mutations I was talking about earlier, there's still folks who do have even that highest risk genotype who never develop the clinical symptoms of Alzheimer's disease. Most people who do have two copies of E4 develop at least biomarker evidence of Alzheimer's. So the amyloid plaques, maybe some of you have heard about, or tau tangles, but not everybody who has the E4 genotype inevitably gets the clinical form of Alzheimer's disease. So I hope that helps clarify some about ApoE and risk of Alzheimer's. We can certainly address any questions you might have in the Q&A section. So ApoE genotyping, it's been around for a while. This link was established back in the 1990s. So there's been a lot of debate over the years. Well, should we use this in clinical practice? In general, we don't see this routinely used in clinical practice, and I think it's for a couple of reasons. One, as I mentioned, the test is not absolutely predictive of Alzheimer's. And that coupled with our limits in prevention options for the disease has led most physicians to steer clear of offering this. And I think that's because there's fear that it may actually have some harm in disclosure. That people may misunderstand what their results mean. They might become distressed if they learn they're at high risk. There's some broader concerns about stigma and discrimination that I'll get into. So I think the fear of the medical community has been, the benefits don't clearly outweigh the harms, so we should not be routinely offering this. But when you ask people in the general public, particularly those who have a family history of the disease, there is often a high level of interest. Folks are often interested because they think maybe it could inform their planning for the future, maybe healthcare decisions they might make. And there's a lot of folks who just have a more general sense that knowledge is power, that they feel like if this is out there, they would like to know this information because it might prove relevant for them someday. And this public interest is relevant to this field of direct-to-consumer genetic testing that some of you probably know about. So the most famous company in this space is 23andMe. And so since 2017, they actually got FDA approval to include ApoE testing as part of the many tests that they do. They test for a range of health-related conditions along with doing genetic ancestry testing. So for almost 8 years now, we've seen that company offer direct-to-consumer ApoE testing, which some in the medical community have some qualms about. But I think it's interesting to see that many more people have probably gotten ApoE information this way as opposed through a physician or a genetic counselor. So our group has been doing a lot of research over the years I've been at this for over 20 years, which is kind of hard for me to believe. I first got involved when I was in Boston with my mentor, Robert Green, who's a physician at Harvard Medical School. So we launched a series of clinical trials known as the REVEAL study, where we looked at the impact of disclosing ApoE genotype. So REVEAL stands for Risk Evaluation and Education for Alzheimer's. So we've done 5 different trials over the years where we've primarily had genetic counselors deliver ApoE information to people. It's been primarily cognitively normal adults, usually middle to older age. The vast majority of them have had a family history of the disease. And we've followed folks usually up to 6 months or a year after learning their ApoE genotype to see what kind of effect did this have on delivering that information. And a variety of outcomes have been the focus of these studies. We tried to look at how do people make sense of these results? Do they understand the meaning? Do they find it useful? What has been their psychological reactions? Do they become distressed or concerned about disease? And behaviorally, what do they do? Do they make planning changes? Do they change their health behaviors? So I'll try to share a little bit of some of the main findings of these revealed trials with you right now. So one thing we've learned is that it's, tricky to talk about this. And so we've learned a lot of good lessons about how to communicate effectively. So we've had to address this concept that might be known as genetic determinism, this idea that when you label something as genetic, people sometimes think about it differently than they might other health information. So on one side of things, we tried to make sure that people aren't overly fatalistic about what their results mean, so that even if they learn they're E4 carriers, they recognize that that doesn't mean they will definitely get the disease. On the flip side, we want to guard against what we might call false reassurance, that just because you're not an E4 carrier doesn't mean you have no risk of Alzheimer's disease. So that's been one aspect of our communication. When genetic testing results are delivered, you have to think about the implications beyond just the individual you're disclosing to. So, thinking about what are the potential ripple effects across families. So, whenever we disclose an E4 result, that means that anybody we give that result to automatically knows that any of their biological children would have at least one E4 allele themselves. So the concept here is that E4 homozygotes are what we call obligate carriers. And so any of their adult children would inherit at least one E4 allele. We have to think about legal issues, and I'll get into this in just a little bit. So there are legal protections against genetic discrimination we think are important for people to know about. And I think, we try where possible to quantify the risks. I think it's more helpful to give people numbers than just general vague labels. And so we've tried to give quantitative risk information, but that can be challenging. People's understanding of probability is not always the greatest. And we've tried to also think about information overload. Sometimes less information can be more. So that's a little bit about health communication issues. We've thought a lot about how do people respond psychologically. Fortunately, we found that when we did follow people over time, that even if people got bad news, they relatively rarely responded with clinically concerning levels of depression or anxiety. And in fact, it was much more often the case that people felt relieved by their results or empowered by their results. So that was some good news. That's not to say that information is completely benign. Our E4 carriers were more likely to have at least some short-term test-specific distress and worry about the disease, but that tended usually to lift after 6 weeks or so. And we had no suicidal reactions, fortunately. Most people were satisfied with their decision to go through with this testing. Most people found this useful at some level to inform their future behaviors and decisions. But I think it's important to keep in mind, our studies tended to not be representative of the general population. And it was kind of a best case scenario where we had expert genetic counselors meeting with them, on multiple occasions. So, well, it remains to be seen how do our results generalize to, much broader groups of the population that may have, lower education levels or lower socioeconomic status. There's a new trial out of Colombia that's looking at disclosure in the Latino population in New York City. So, for example, that's an interesting example of trying to diversify the research participants who take part in these kinds of studies. Um, so switching gears from how did people respond psychologically to how did they respond behaviorally, we found that people who found out they were at elevated risk did change their health behaviors and make advanced planning changes in a variety of ways. Uh, Many folks reported some kind of vitamin or supplement use, like vitamin C, vitamin E, ginkgo. These are uh, vitamins or supplements that some epidemiological studies have suggested might be useful. We found that people, in terms of advanced planning, the most common change here was change in long-term care insurance, and I'll get into some of the implications of that. And interestingly, in our third trial, we randomized people to learn about ApoE and Alzheimer's risk alone, as opposed to learning about ApoE and risk for both Alzheimer's and heart disease. Because you remember I said that the E4 allele is also a modest risk factor for heart disease. And interestingly, when in that arm where they were getting risk for both diseases, that group was more likely to report a range of health behavior changes, including diet and exercise. And so I think the fact that heart disease, we have much more evidence that changing these things can reduce disease risk, that seemed to be motivating to our participants when we gave the information in that format. But back to this vitamin and supplement issue, I do think it's a broader issue for the field because if you go to any health food store, you might see products like this on the shelves. Our nutraceutical industry is a relatively unregulated industry, and so they're allowed to make these kind of broad claims. They can't make claims specific to Alzheimer's disease, but they can talk about things like nutrition for the brain or brain health. And I do feel like sometimes these give the impression that these are perhaps more efficacious than they truly are. And it's not just nutraceuticals. I think there's a whole range of products out there that I think are capitalizing on older adults' fear of Alzheimer's and related dementia. So I think we need to be mindful of how we regulate these industries and how we provide health education. And so one kind of tagline that I like to use is that if it sounds too good to be true, it probably is. There are some products out there that are making some pretty bold claims about benefits that I think often go beyond the evidence for benefit. Um, I mentioned earlier long-term care insurance changes were a relatively common behavioral response to ApoE information. So I think it's important that folks know about this Genetic Information Non-Discrimination Act, or GINA. So this is a federal law that was passed back in the Bush administration in 2008. So importantly, it prohibits the use of genetic information by health insurers or employers. So it would be illegal under GINA, for example, for a health insurer to deny coverage because someone's at high genetic risk for a condition, whether it's Alzheimer's, cancer, any other condition. Health insurers are not allowed, for example, to deny people coverage or raise their premiums because of their genetic status. And then similarly, employers are not allowed to use genetic information against people in hiring or promotion decisions, or can't terminate someone because of their genetic status. So I think all of us would probably agree that makes good sense. We can't control our genome, so we shouldn't be discriminated because of it. But there are some gaps in GINA. So GINA does not apply to long-term care, does not apply to disability or life insurance domains. That's not to say that those insurers are engaged in genetic discrimination. It's just to point out that this federal protection is not comprehensive. So some have suggested, should we expand GINA, or sometimes states go beyond this floor of coverage that GINA provides? And so these kind of legal issues, I think, are important for patients and families to think about because sometimes people are using genetic test information to inform these insurance decisions. Um, our Reveal projects have also looked at, can we disclose ApoE information in a more efficient manner? Can we move away from this very time-intensive model of face-to-face clinical encounters that has traditionally been the approach in genetics? And can we maybe streamline the approach so that we can actually expand the reach of these services? So I mentioned the kind of the limited workforce of genetic specialists. So our second trial, we did compare our traditional protocol to a more condensed protocol. So we were able to deliver this in less than half the time. You can see 33 versus 76 minutes. And we found comparable results in some of our key outcomes of psychological distress and people's comprehension of the information. And then in Reveal 3, we compared an in-person protocol to a telephone disclosure protocol, and again found that these were roughly equivalent on our key outcomes. And in other realms of genetic medicine, we're seeing even the move towards using, kind of AI and chatbots to deliver some of this information. Sometimes that might be more appropriate on the pre-test education than the post-test. But I think we're seeing the field try to think about ways, how do we deliver this information more efficiently so that more people could be reached. And that brings me to this idea of genetic testing within the context of research studies, particularly research studies that are testing new therapies for the disease. So, at our Alzheimer's Center, we routinely collect genetic information across our whole range of studies. And so I think this might ultimately result in things like, you may have heard of this concept of polygenic risk scores, this idea of not just thinking about one gene like ApoE or presenilins, but maybe really combining a whole range of genetic risk factors. So we're not out there at that point yet in clinical practice, but I think research is really they're really testing a wide range of genetic factors that might be relevant here to Alzheimer's. But usually in these studies, people don't get back their individual genetic results. But I think we are seeing a shift where more sites are starting to do this kind of disclosure of individual research results. And in fact, genetic testing has become a key part of determining eligibility for some of these drug trials that you may have heard about that are trying to identify high-risk groups to test out new therapies that might actually delay the onset of Alzheimer's in the first place. So some of these you may know about. Sometimes they use genetics, sometimes they use other biomarkers, like you may have heard of amyloid imaging, where you can detect amyloid plaques versus via a PET scan, for example. But some of these studies have used genetic testing. So I'll talk about this Alzheimer's Prevention Initiative that's looking at some of those rare mutations I was talking about earlier. Some studies have used ApoE, like the generation studies enrolled just E4 homozygotes. So there was a famous study in Colombia where they were enrolling folks who had one of the rare genetic mutations, and they were testing out this drug, crenuzumab. And they found, unfortunately, the trial was negative in that the drug did not seem to slow symptoms in the mutation carriers in this particular trial. And interestingly, in this trial, the participants were blinded to their own genetic status, not just blinded to whether they were on drug or placebo, but also to whether they had the mutation or not. And in this context, in this cultural context, most folks did not want to know their genetic status. So this was, kind of a disappointment for the field that this drug did not prove to be efficacious in delaying onset in mutation carriers. And it kind of, like many other studies that have been done, it seemed like this anti-amyloid approach, has its limitations. And so this is kind of a broader debate in the field that some of you may know about. Is we've really invested a lot in particular anti-amyloid approaches as opposed to other potential routes for therapy. And so there's been a lot of debate over, have we kind of given this anti-amyloid angle too much attention, and should we think about other potential pathways like tau tangles or inflammation in the brain? And also, I think we're starting to see more drug trials, fortunately, that look at those approaches as well. So, related to this idea of genetic disclosure to determine eligibility for a drug trial, I mentioned the generation study led by my colleagues at Banner Institute in Arizona. So this was a study where, to be eligible for the drug trial, you had to be an ApoE4 homozygote. So we looked at disclosure within the context of this trial, and it was a huge trial. So we were able to look at disclosure to almost 10,000 participants. And so, it was almost 140 sites, a multinational trial. And we found that ApoE disclosure did fortunately improve participants' knowledge of genetics, particularly the E4 homozygote seemed to really tune in to the education and took away some valuable information. In terms of the psychological impact, we found that the homozygote group, those who were E4, did have increased anxiety and distress at 1 week, but then that tended to abate over time. And again, like we found in our reveal studies, clinical anxiety and depression was pretty uncommon in this. So again, this is all evidence that if done properly, ApoE disclosure can be safe and does not necessarily cause significant psychological distress. And so with this group, we're working on a new study that's just getting underway. We're again trying to think about different means of delivering this information. So we're going to be testing both kind of a web-based educational program as well as an interactive chatbot to walk participants through. So again, can we use technology appropriately so that we don't always have to have experts face to face with participants for every step of the way, that there might be some elements of disclosure that we could offload to these technology-driven approaches. So we'll see how these studies come out, but just wanted to make folks aware of this new project that we've got underway. So let me shift gears here to talk now. I've been talking to date about disclosure in people who are, asymptomatic. Maybe they have a family history, but they have no current symptoms, but they're just interested in learning their future chances of developing the disease. But when you think about pharmacogenetic testing, you're thinking about people who already are affected with a condition and they're thinking about a medication that might treat the disease. And so when we talk about pharmacogenetic testing, we're talking about genetic testing that might inform a medication decision. So, for example, should I go on this drug in the first place at all? Or if I do, what are my chances of side effects from that condition? Or what are my chances of not responding at all? And so we see this done in other realms of medicine. Some drugs even have black box warnings that say you have to do genetic testing before prescribing this because people with maybe rare genetic variants might be at risk for even fatal reactions to medications. So we see this in the context of treatment for other medical conditions done a lot now. And it's become relevant in the case of Alzheimer's disease because some of you probably know about these new anti-amyloid therapies that we've had a couple approved in recent years. So it turns out that ApoE testing could be a relevant test in the context of treatment here. So you may have heard about lecanemab and donanemab. These are both now approved for treatment of mild Alzheimer's, so whether and even mild cognitive impairment. And so both of these drugs, if you know anything about them, you know that um, they do seem to slow the decline of the disease. So they have benefits for both cognition and patients' functioning. So they were very heralded and have been, important new treatment options for folks. But they certainly are not, a magic bullet to stop the disease in its tracks. So they're more just kind of slowing decline as opposed to completely arresting the disease. But there are important side effects to be aware of for both of these therapies. And the prominent one is known as ARIA, which is a complicated acronym standing for amyloid-related imaging abnormalities. And so there's kind of two subtypes of these side effects, ARIA. So the ARIA-E, the E stands for edema, so that refers to swelling that can happen in the brain. And the ARIA-H, refers to hemorrhaging. So there can be these microbleeds in the brain that can occur as well. So these are, fortunately, when these are observed, they're typically benign. That is, they don't result in any notable symptoms, but they can sometimes lead to symptoms like headache or nausea. And in rare cases, they can even lead to hospitalization. So fortunately, that's rare, but these are important side effects for people to know about before going on these medications. And lo and behold, ApoE4 carriers are at elevated risk for these side effects. So ApoE testing is recommended to inform people's treatment choices. So if you learned you're, for example, you're an E4 homozygote, you might have second thoughts about whether to even go down this road of being on one of these medications. Or if you do go down this road, maybe you and your physician would want to more closely monitor for these side effects. So the monitoring can happen via neuroimaging to kind of take pictures of the brain and see what is happening. So ApoE testing is now recommended in conjunction with these therapies to help inform what's the best treatment decision. And if you can see, the reason why is data like these. So this is a little bit of a complicated chart, but you can see if you look at these are the rates of having these ARIA side effects in the clinical trial for lecanemab, which was approved in 2023. And if you look, you can see, these rates are relatively low in the placebo group. But if you look on that far right column, that's people who not only got the drug lecanemab, but are also E4 homozygotes. So you can see across the board, the risk of ARIA is much higher in that group. So when you think about ARIA E, that group is having a almost 33% chance of having the ARIA E as opposed to 1.7% chance in placebo. And when you look down at the ARIA H, you can see the risk of side effect is 39% of the E4 group. We saw that happen as opposed to 9% in placebo. The news is better when you look at were these side effects actually symptomatic or did they result in a serious event? There you can see, the risk of a serious ARIA-E event is only about 2% in the E4 homozygote group and 1.4% for ARIA-H. But still, it's notable enough that it might give you or your physician pause before going on this kind of medication. So these kinds of risk numbers, I think, are important for patients and physicians to weigh. And that the difference was stark enough by ApoE genotype that we see experts recommending that this be done routinely before starting one of these new therapies. But it's interesting, as I mentioned before, usually in genetic testing for Alzheimer's, it's usually genetic counselors who are delivering this information. But I think we're seeing neurologists or other physicians who are prescribing the medications. My understanding is that a lot of them are taking this on themselves. And so it's kind of a new skill for neurologists, many neurologists to learn is, this how to disclose ApoE sensitively and think about, the different issues that come up in genetic testing. But physicians do disclose risk all the time. So I think hopefully the neurologists who are doing this ApoE disclosure are doing this effectively. So that's just a little bit on this, how these new therapies for Alzheimer's are implicating ApoE genetic testing in a new way than we've thought about it before. So I guess to close, where's the bottom line here? What should we be telling, whether we're practitioners working with patients or whether you work, a loved one thinking about doing this yourself? What are the recommendations here? Well, again, the broader medical community has been fairly skeptical. So these are a little bit outdated, I would say. This is 2011, but they are the latest guidelines from some major professional groups in the field. I think there might be new guidelines coming out relatively soon. But the most recent published guidelines, you can see, they say we don't think this is the greatest idea, that it should really kind of be entered in sparingly, and that direct-to-consumer genetic testing is not a good idea either. So there's a lot of wariness around this for asymptomatic populations at large. I guess I feel like maybe these are a little bit too paternalistic. I'm not quite as harsh as feeling like we should never do this. But I do feel like if people are going to pursue this, they should be informed going into it. And so I like this. There's an online decision aid called genetestornot.org. So whenever I have friends or family ask me, should I think about ApoE testing, I feel like this is a nice online tool. It kind of walks people through what is ApoE testing, what are the pros and cons, what are the benefits, what are the limitations, what are the risks. So I feel like these kinds of information sources can be helpful for folks before deciding to pursue something like this, whether it's through a physician or through a direct-to-consumer company, what have you. Um, when you think about kind of for patients who have early Alzheimer's disease, these are the latest appropriate use recommendations for that drug lecanemab that I just talked about. And I think the recommendations probably also generally apply for donanemab. And you can see the segment here that's most relevant for this talk of these recommendations have to do with ApoE testing. So this kind of reiterates what I was talking about earlier, that notes how ApoE4 carriers do have increased risk for these ARIA side effects. And so this group of esteemed experts in the field is recommending routine ApoE genotyping before initiating drug therapy. So I think that was important to note for the field, and I think we're seeing this happen. Interestingly, what I'm not totally clear on is how are people ultimately dealing, for example, with the E4 result. I think some physicians might say they say, well, we shouldn't even do this at all if that's the genetic test result, whereas others might feel like it's still kind of ultimately an open decision. But I think some folks are feeling like the side effect risk is too much for that genetic subgroup, so that they're suggesting we shouldn't even try this at all because of the fear that it might result in those inflammation or microbleeds that I was talking about earlier. So hopefully this talk has given you a feel for some of the issues at stake in genetic testing for Alzheimer's disease. So as I've talked about, there's several different types available that could be considered. None are recommended for routine care in asymptomatic populations, but as we were talking about, ApoE testing is now recommended to inform decision making for people diagnosed with MCI or early Alzheimer's who might be considering these new therapies. And I hope I've convinced you that genetic testing does raise an interesting and important set of ethical, legal, and social considerations. The information has potential implications for family members. There's legal issues to think about with genetic discrimination. There's psychological issues to think about in terms of how people respond emotionally to learning this information. There's challenges around how do we convey this information effectively, given how complicated it can be. So I think it's important to think about those, what we call ELSI issues, ethical, legal, and social implications for genetic testing in this space. So with that, why don't I pause? And I hope I've left us enough time to get through various questions. It looks like some have been entered in the chat. So I will stop
Yeah.
sharing my screen and turn it over to Stephanie, and you can just pop some questions at me. I'll do my best to
Yeah,
respond.
we'll try. We have a lot of them coming in, so we'll try to get through as many as we can. The first question I have is, does insurance usually cover this genetic testing?
Yeah, so I think typically insurance would not cover it for asymptomatic populations. So again, partly because, as you saw from those professional organization recommendations, they're saying they don't think it is, um, worth doing in the first place. So it would be hard to imagine insurance companies covering ApoE testing, for example, for someone who has a family history and they just want to know their risk. I think it's early enough that I don't know for sure in terms of ApoE testing in the context of, decision making for these new anti-amyloid therapies. I'm not totally aware yet because those are just being rolled out now. So I'm not, and maybe if we have some clinicians in the audience who know better than I, they could perhaps chime in, but I'm not as sure there. I think there would be a better chance of coverage there because again, when I show those appropriate use recommendations, oftentimes insurance companies, if they see these kind of consensus statements that are supporting use, that they might be more amenable to coverage. So I think it kind of depends on what population, what use are you talking about. But I think for most people, if they're just interested in genetic testing to learn risk, we're not seeing insurance coverage.
Are you following participants in the REVEAL study prospectively? I wonder whether the lifetime risk of AD will be the same among E4 carriers or homozygotes who learn their status early and are able to engage in healthy lifestyle factors.
Yeah, that's a great question. We are not following them, over the course of their lifetimes. The longest follow-up period we had in one of our studies was 1 year out. But it's a great question. Maybe it's a good grant idea. We could go back to some of these folks, particularly those who like learned in their, 50s. Are they doing things? Our studies were relatively small in size, so it might be hard to detect a true benefit on that realm. But I think the point is well taken that it's kind of unknown. A lot of folks in middle to later life are getting these messages about maintain your brain and engage in health behaviors, and we're still trying to figure out as a field, well, just what is the power of these risk reduction techniques? We're still trying to figure that out. The Alzheimer's Association does have a study called the Pointer Study, where they're looking at the benefits of some of these multimodal behavioral interventions. So not using drugs, but thinking about, exercise, thinking about diet, and what are the protective benefits of doing these behaviors.
Okay. How concerned are you about doing research in your field with recent cuts in funding from the current administration? And how do we feel about see our field being affected?
Yeah, I'm very concerned. I think all of us in science and medicine have been taken aback by just the extent of cuts, whether we're talking about reducing indirect costs to institutions for medical research, or just kind of completely pulling the plug on certain lines of research. I think it is very concerning. I think NIH has been the world's foremost funder of biomedical research, and it used to be that we had tremendous bipartisan support for this. So I'm definitely concerned. I do think there is a lot of uh, hope, given that Alzheimer's disease is such a prominent public health issue. It affects over 6 million Americans, no matter your red state, blue state. So I would like to think there would be pushback if there continue to be cuts that would particularly affect Alzheimer's disease research in particular. But the short answer is yes. I'm very alarmed, and if you agree with me, I would encourage you to kind of voice your concern to your elected representatives, because I think it's only through this kind of pushback that maybe we can think about reversing some of these decisions that are being made that I think are quite short-sighted.
All right. Thank you for your excellent talk. Do we know why ApoE4 pathophysiologically leads to increased risk of ARIA?
That's a good question. I think we don't know for sure. And in fact, we're even still learning, well, why does it even affect development of Alzheimer's itself? I think there is some suggestion that E4 does seem to be implicated in the formation of amyloid plaques in particular. And if you know anything about Alzheimer's, you know that amyloid plaques are often kind of the first warning sign of the disease, and do start to develop in the brain much earlier than any cognitive symptoms appear. So E4 carriers do seem to be at higher risk for this kind of earlier deposition of amyloid plaques. And I think ApoE has also been implicated in some of the brain inflammation. So that might help account for that, at least that ARIA-E subtype of side effect. So there seems to be something about E4 status that increases the chances of having these kind of edema responses in the brain. So I think we're still figuring it out, but those would be some kind of early guesses about some of the underlying pathways that the questioner is asking about.
Is the medical community concern with direct-to-consumer testing arise from the unreliability of the tests, false positive or negatives, or lack of counseling about the test results and implications?
I think it's probably more the latter. It's an excellent question. I think the fear is that because these things are done without requiring that you meet with any kind of medical professional. There is some education provided on the website, but I think the fear is that people will kind of maybe misinterpret the results because they're just getting it online. And they don't have kind of a recourse if they have kind of immediate concerns or questions, typically. So I think that has been the fear. I mean, I think the tests themselves are usually pretty accurate at calling the genotypes they're looking for. So, for example, if you got an E4 result from 23andMe, I think you could be pretty confident that that is, a true finding. Um, so I think the concern is more, I think, around kind of the education that's provided and people not doing it in the context of kind of an ongoing relationship with a healthcare provider where they could, have follow up. So I think I get it's a little bit of a side note. I think one BRCA testing is actually done on 23andMe for, BRCA is this gene where if you have a mutation, it elevates risk for hereditary breast and ovarian cancer. And another concern for that test in particular that it only looks for a few known mutations. So the fear is that, let's say you got they didn't find it. That doesn't mean they looked for all possible mutations in the BRCA gene. So that's another concern, is that people would remember I talked about this concept of false reassurance. Will people walk away thinking, oh, I'm totally in the clear, when it didn't do as comprehensive a job testing as you would see in a clinical test for BRCA? If that makes sense.
All right. If we have genetic testing results and are we obligated to share these results when questioned by life insurance applications?
Yeah, I would think so. I mean, I think, the idea is if you are withholding, if they ask about a specific genetic test and you know your results, I think to not disclose that would be risking being found out for kind of a fraudulent application. So that's why genetic counselors, they often tell people, well, if you're considering purchasing some kind of insurance, they often encourage people to do so before the results are back. That way you can honestly say you don't know your status. So I think that's my general response there. But I hope I didn't freak people out by bringing this up. I don't think it's like life and disability or long-term care insurers are kind of rampantly engaging in genetic discrimination against people. I think, and with Alzheimer's, you could imagine there's kind of quicker and easier ways to identify high-risk groups. You could even do like a quick clock drawing task, or some brief neuropsych measure could probably give you valuable risk information if you're an insurance company. But I do think it's important that people recognize what the laws protect and what they don't protect against, so people can kind of factor that into their decision making.
Okay. How does the recommendation of genetic testing differ for someone with a family history of early onset versus late onset?
Yeah, so I think if someone had a prominent family history of early onset disease, so we're usually thinking, before age 65, and like sometime even in one's 40s or 50s. So if you have that kind of family history, we have multiple cases, particularly multiple what we call first degree relatives affected, so parents or siblings, then I think you are in a different kind of risk status, and that you might benefit from a consult with one of these specialty neurogenetics clinics. So U of M, my colleague Wendy Ullman is a genetic counselor who's been doing this for many years. So she sees patients from families that have that kind of family history where, again, it's multiple affected family members earlier than typical age of onset. And if that's the family history, then genetic testing for those rare mutations that I mentioned might be appropriate. So these are the presenilin and APP genetic mutations that I mentioned at the outset. But those, fortunately, people with those kinds of family histories are relatively rare. So it's much more common that people maybe have, one or two family members affected, or don't have and or the age of onsets maybe in the late 70s, 80s, 90s, etc.
Do you have any thoughts to share on the investigative journalist Charles Pyler's Science magazine on fraud uh, delaying search for a cure for Alzheimer's disease?
Yeah, so I think the that question is referring to this new book that just came out. I think there was a big New York Times op-ed recently by the same author. And so I haven't yet read the book myself, but it's kind of stirred a lot of, controversy in the Alzheimer's field. I think the journalist does document some concerning research ethics, including scientists at the National Institute on Aging. And so I think it kind of appropriately raises awareness and concern about wherever we have fraud in research. It's incredibly damaging to public trust. It really, sets the field back. And so I do share the concern from that standpoint. I teach, a public health ethics course, and we talk a lot about, these sensational cases really do make headlines and undermine public confidence. That said, I do feel like what I've read of the journalists' claims for how the broader effect on the field have perhaps been overstated. I think there's been a lot of outstanding research in the field that still stands up today. I think the implication was, oh, did we have we put too many eggs in this basket of anti-amyloid? And I think, there's an argument to be made there, but I think it's not like we have stopped investigating other potential treatment avenues. So we do have a robust clinical trials pipeline that's looking at, tau-based therapies, that's looking at anti-inflammation therapies, that's looking at, social behavioral interventions. So, and in fact, I think it was such the author got the attention of enough Alzheimer's researchers in the field who have now like signed this open letter where they are criticizing the journalist for maybe saying that, oh, making assuming that this kind of research ethics concern really just kind of invalidated, whole swaths of Alzheimer's research. They feel like that the case has perhaps been inflated for that. So that's kind of a long-winded answer, but it is certainly very timely. It's making a lot of headlines, and so I thank the questioner for bringing that up.
Is it possible that other genes that have yet to be identified may play an outside role in determining one's likelihood of getting Alzheimer's?
I would be surprised if we find more genes that are that super high impact, like the rare mutations I mentioned, or even ApoE. I feel like we probably those are probably the quote unquote low hanging fruit. It's certainly possible, but I would probably, if I had to predict, I would say we would probably find more um, of those kind of what we call lower penetrance genes that do play a role. And that if we can kind of combine them in one, like I think I mentioned this concept of the polygenic risk score. I think we could still add them up, if you will, but I don't think we're going to find single genes that are hugely determinative beyond what we have found to date, if I had to predict. Predicting is dangerous in science, but that's my best guess.
All right. We still have quite a few questions left. We're going to try to get through a couple more. Um, will the slides be available or the recording be available? Yes, there will be a recording available of this. It's being recorded right now, and it should be up on YouTube in a couple weeks. If you would like a um, a direct link, I will put my email in the chat for everybody. So you just email me, and I will be sure to get you that link whenever this video is up on YouTube. All right, let's see. How can we directly support your work? Do you have a specific research fund we can donate to?
Wow, what a great question. So, yeah, I think our center, the Alzheimer's Center that I'm affiliated with, the Michigan Alzheimer's Disease Research Center, we do certainly welcome donations, and that would be kind of the cause I would suggest. So this is we're a federally funded research center of excellence. We span U of M, Wayne State, and Michigan State. And so would certainly appreciate any kind of support because this really does allow us to do more. I mean, the grant funds are are certainly helpful, but we do rely on philanthropic donations as well and use these in a variety of research programs. And maybe, Stephanie, you could put a link to our center website that kind of describes our program of activities as well.
I'll do that. Let's do one more question real quick. Thank you for the excellent talk. Do we know why ApoE4 is linked to higher risks of ARIA?
Yeah, I
We,
think we
I think we
covered that
already
before.
covered that question. Let's see. Is there evidence that quercetin is effective in preventing Alzheimer's or slowing dementia?
I'm not familiar with any research in that realm, so I can't say for sure there.
Let's see. Having a mother, two aunts on a mom's side, and grandmother with Alzheimer's, would you consider genetic testing knowing that none of them have had genetic testing?
Yeah, I think again, like I was saying earlier, if you have kind of multiple biological relatives, particularly first degree relatives, and if the age of onset is, kind of lower than we typically see, that might be worth at least an inquiry with one's physician who might then be able to refer you to genetic testing and counseling. But yeah, I think that it's at least worth exploring. Well,
All right. Do you have time for any more questions or we got to pop off because we are at that 1 o'clock mark now?
I could take one more.
One more. All right. Let's go through here. Oh, goodness, we have so many.
And actually, if we don't get to your questions, people can feel free to email me. My email is jscotr@umich.edu. So if we don't get to these today, feel free to email me.
All right. Which is the genotyping lab used at Michigan Medicine? Does U of M have a biobank for these genetic results?
Yes, we do have a biobank. We do, kind of routinely collect ApoE information on most of our research participants affiliated with our centers. So we typically have not disclosed those unless it's in the context of the Reveal trials that I mentioned. I Off the top of my head, I don't remember the specific uh, lab that's used, since I'm not directly involved on that front. But we do routinely collect not just ApoE, but other genetic information, and it's, very protected. We take genetic privacy very seriously, and so we do tend, across many of our studies to collect genetic information.
Okay, well, thank you so much for your time today and all of the time you dedicated to answering all these questions. Thank you, everybody, for showing up. It was a really great talk, and I hope you join us for more speaker series in the future.
Yeah, thanks so much. Great to have such an engaged audience, and thanks, Stephanie, for hosting.